This is Sickle Cell and TCD, and you are watching TCD with Tony. Today we're going to discuss sickle cell disease, the history of TCD and sickle cell disease, the normal and abnormal, the conditional parameters, what are the mean velocity cutoffs for each of these thresholds, what are the treatment options, the new and improved treatment options, and where are we today with all of this. What is sickle cell disease? Sickle cell disease is an inherited red blood cell disorder in which the red blood cell is misshapen, causing vasculopathy in the intracranial cerebral arteries. The sickled red blood cells are fragile, and they easily break down and release proteins that increase inflammation, clotting, endothelial damage, and can cause vasoconstriction. The major cause of cerebral infarction in pediatric sickle cell disease is because of this misshapen red blood cell. You can see on the right, on the bottom corner, this is what a sickled red blood cell appears as compared to a normal red blood cell in the top right corner. The risk of stroke is highest in the first decade of life for our pediatric sickle cell patients. They are at a risk of stroke 333 times greater than that of a healthy child without sickle cell disease or heart disease. Children with abnormal TCD studies have a greater risk of 3,000 times for stroke, and approximately 11% of sickle cell patients have clinically apparent strokes before the age of 20. Sickle cell is a progressive lifelong illness, and it can cause long-term complications, and it does affect everyone differently. Now, sickle cell presents at birth, but doesn't begin to cause complications until about 5 months of age because of the fetal hemoglobin. The fetal hemoglobin has an anti-sickling property, and it will protect the red blood cells from sickling. Fetal hemoglobin is replaced shortly after birth by adult hemoglobin. However, in sickle cell, the fetal hemoglobin is replaced by hemoglobin sickle. This can cause the red blood cells to clump together, and this is the cause of the red blood cells to sickle. This misshapen, sticky red blood cell will affect all the organs in the body. There are different types of sickle cell disease. The most severe form is hemoglobin SS. This is when a patient will inherit one gene from each parent that code for hemoglobin S. It is an abnormal form of hemoglobin that causes the red cells to become rigid in that sickled shape. This is commonly called sickle cell anemia, and it is the most severe form of the disease. Today we'll discuss how this will impact the blood flow to the brain, increasing the risk of stroke, and how to improve the quality of care in this patient population. What is hemoglobin and hematocrit, and how does it relate with sickle cell? Hemoglobin and hematocrit are commonly confused. The key difference between hemoglobin and hematocrit is that hemoglobin is a protein, and it is presented mainly in the red blood cells of almost all vertebrates, and hematocrit is the measurement related to the total blood count. So both hemoglobin and hematocrit are used to diagnose anemia, which is a disease condition that develops when the blood produces a lower than normal amount of healthy red blood cells. Therefore, these two terms are commonly mistaken. The function of hemoglobin is mainly to transport oxygen from the lungs to other tissues and to be used in cellular respiration. From the tissues, carbon dioxide is transported back to the lungs as carboxyhemoglobin. How does hematocrit affect TCD? People with sickle cell have abnormal hemoglobin, which causes their red blood cells to become rigid and sickle-shaped. This can lead to pain, infections, and low hematocrit. The hematocrit is the proportion by volume of the blood that consists of red blood cells. The hematocrit is expressed as a percentage. For example, a hematocrit of 25% means that there are 25 milliliters of red blood cells in 100 milliliters of blood. You can see the chart on the right that is plotting out the normal hematocrit ranges by age. At 1 month of age, 37 to 49% is a normal hematocrit range. Transcranial Doppler performed on 124 anemic children aged 3 to 18, primarily with sickle cell anemia, and the goal was to determine the relative influence of age and hematocrit on intracranial blood velocities measured by TCD. So in contrast to children without anemia, the mean velocities were higher and were significantly correlated with hematocrit, but not with age. These findings indicate that knowledge of the hematocrit is necessary when interpreting TCD findings in children with sickle cell disease, and probably in young patients with anemia from any cause. It is an inverse relationship of the hematocrit with the TCD mean velocities. It is a common thing to note when performing a TCD if your hematocrit is elevated or decreased. The introduction of TCD in sickle cell disease began with pioneer Dr. Robert Adams. This was an evolution of a 20-year effort to develop a strategy to prevent stroke in pediatric sickle cell disease. From a chance meeting in Germany in 1986 to a press conference in Washington, D.C. at NIH in 1997. 1982 was the introduction of TCD for the detection of subarachnoid hemorrhage related to vasospasm by Rooney Oslin. The big question at that time was, would TCD work for sickle cell disease? So the evolution of the STOP protocol began. The STOP protocol is the stroke prevention in sickle cell anemia. This is one of the most effective stroke prevention strategies in medicine. From the Medical College of Georgia cohort in 1992, STOP in 1998, STOP 2 in 2005, SWITCH in 2012, and TWITCH in 2016. Once it was clear the risk of stroke in sickle cell disease was related to transcranial Doppler, then acting on Doppler will prevent stroke. Now, the STOP1 trial was the first randomized controlled trial of regular transfusions in sickle cell disease for any indication. It was the first randomized controlled trial based on transcranial Doppler. And it was the first randomized controlled trial for stroke prevention in children for any indication. Here is a review of the stroke prevention trial in sickle cell anemia, the STOP trial design, and the STOP trial results. The STOP1 trial in 1994 was a multi-center clinical trial. This demonstrated such a significant benefit of chronic red cell transfusion in reducing stroke by 90% that the study was halted. The study was halted before its scheduled closure on the advice of the study's data and monitoring board. Based on these findings, the National Heart, Lung, and Blood Institute issued a clinical alert. They recommended the TCD screening of children with sickle cell disease. And they also recommended chronic transfusions to prevent stroke for those who are at high risk. Here is a publication in 1998 showing the prevention of the first stroke by transfusions in children with sickle cell anemia, that this was related to the transcranial Doppler results. It was proven that high mean velocities on transcranial Doppler were identifying patients, sickle cell patients, that were at high risk for stroke. The next trial was the STOP2 trial. Now, the STOP2 trial was the highest quality data based on the STOP study. Here is a review of the design and the comparison to the STOP1 trial. The STOP2 trial was also halted prematurely. The National Institute of Health recommended that transfusions be continued indefinitely for children at high risk of stroke in sickle cell disease. Next, we're going to talk about the Twitch study. First, you may ask, why would you stop transfusions? Transfusions are preventing strokes. They are solving the issue at hand. However, chronic transfusion were causing other issues, such as iron overload. So TCD with transfusions, changing to hydroxyurea, the Twitch study, this was for high-risk children with sickle cell anemia and abnormal TCD velocities. After 4 years of transfusions and without MRA vasculopathy, hydroxyurea therapy can substitute for chronic transfusions to maintain TCD velocities, and it helps prevent primary stroke. Now, the impact that transfusions made at preventing stroke was clear. Reduction in stroke in children with sickle cell disease has been documented. TCD and STOP have changed the landscape of stroke in sickle cell disease. It dramatically reduced the first stroke in children. It reduced hospitalizations for strokes in sickle cell disease pediatric patients. Now, despite the compelling reduction in stroke risk, the acceptance of the STOP strategy was limited by concerns of iron overload with chronic transfusions. Thus, hydroxyurea and the Twitch study. Gradual decrease in transfusions and increase in hydroxyurea was proven beneficial. Next, Dr. Robert Adams published Big Strokes in Small Persons. What this entailed was a TCD risk stratification to determine the criteria of mean velocities in categories. So we could determine if mean velocities were normal, conditional, or abnormal to isolate individuals who required additional medication or therapies. Now, normal parameters were less than a mean velocity of 170 centimeters per second. Our conditional mean velocities are from 170 to 199, and 200 centimeters per second and above categorized abnormal mean velocities for patients that were at a greater risk for stroke. This was a huge accomplishment in categorizing the level of disease and the level of needs required to treat this patient population. Now, TCD on pediatric population is slightly different when compared to the adult population. With TCD, you primarily look for different depths where your vessels and the anatomy will lie. With the pediatric population, you'll see there are some differences in not only the vessel depths, but the window location. The temporal windows are most commonly at window 1, as you see in the center picture. Window 1 is just in front of the ear. This is the most common window for the adult population. Now, with pediatric population, the most common windows are 1 and 3. So if you have your probe placement just in front of the ear or a bit more center on the side where the temporal windows lie. Now, your window will also determine the angle of your probe. So if you're at window 1, you'll be angled a bit more anterior to isolate your middle cerebral artery. Now, the specific protocol in place for our pediatric sickle cell population still entails the MCAs and terminal ICAs, ACAs, and PCAs bilaterally. We primarily focus on the MCAs and the terminal ICAs for this population. We will also obtain the basilar artery, and some sites do include the vertebrals. However, as we mentioned, the MCAs are the most prominent vessel to be concerned with in this patient population, and we will sampled throughout the length of the vessel every 2 millimeters from as proximally to as distally as we can find it for any abnormalities. Now, the depths of vessel location in this patient population are slightly different when compared to an adult. An adult, your MCA-ACA bifurcation can be commonly found at 62 millimeters. When we are scanning our pediatric patients, the MCA-ACA bifurcation can be commonly seen at 52, 54 millimeters, depending on the patient's age and size. There is one limitation that is unique to this patient population, and that is the vitamin D deficiency. So it can lead to loss of bone density in this specific patient population, in turn causing some limitations when trying to insufflate through the temporal windows. Just some things to be aware of when scanning your pediatric patient versus an adult patient and in sickle cell disease. Just to review a step-by-step guide for a TCD protocol for pediatric patients with sickle cell disease, you will use your dedicated Doppler machine with a 2 megahertz probe, initially placing it at the right temporal window, window 1 or 3 as we mentioned in the previous slide. You will find your best window. You will move your probe in small circles, almost as a flashlighting around, to identify that best window and the best signal through it. But ideally, you are searching for your highest mean velocity. So you're not only looking for a strong signal, you're looking for where you're going to find your highest mean velocities. So you'll initially find your window. And once you find your window, you can keep your probe where you have it at that location and just make small adjustments, move the probe angles around to see if you can find the highest mean velocities. You will typically begin at a depth of 50 millimeters, finding your best signals, and you will take your depth as superficial as you can. With our pediatric sickle cell patients, this can commonly be taken down to about 36, 34, 32 possibly, to begin taking your pictures at that level and increasing your depth every 2 millimeters and taking pictures throughout the length of the vessel. As I mentioned, you're looking for your highest mean velocities, so don't ever settle for low signals. Once you find a signal, don't just start taking pictures. You will have to optimize every signal, and that includes with every depth increase. So not only are you looking at the depth and the mean velocity when you are scanning, you're looking at all of the parameters on your machine. You want to know what your filter is set at, your scale, all of the different parameters on your machine you will be optimizing. You will angle anteriorly initially to isolate that middle cerebral artery. You will decrease your depth to the most superficial segment that is visualized in M mode, and you'll walk through that whole band that you'll see in the M mode to really know if there are any high mean velocities throughout the length of the vessel. Now, all the other vessels that you will image and isolate and take pictures of will determine on what is required at each institution. But other best practices include validation of the criteria. Whatever criteria you use should be validated. And the ways to do that are with angiograms, CTAs, MRAs, and other clinical findings. Now, where are we today with TCD and sickle cell disease? Primarily, we will perform TCDs annually on our sickle cell patients beginning at the age of 2. Every year, these patients will have their TCD repeated until at least the age of 16. If the TCD becomes conditional, if it exceeds the mean velocity of 170, or if it becomes abnormal, exceeding the mean velocity of 200, these TCDs are repeated more frequently so that treatment methods can decrease these mean velocities and decrease the risk of stroke. Now, the most common treatment options have been hydroxyurea and chronic blood transfusions. However, we have included more treatment options that we are going to discuss in the next slides. Now, the multitude of treatment options that we have today for sickle cell disease include, as we mentioned, the red blood cell transfusions and hydroxyurea, the medication therapy, chronic blood transfusions, gene therapy, stem cell transplants. All of these different treatment options should be discussed with the family and physician to determine the best treatment method for each individual patient. However, we will review a few of these different options for treatment, and one in particular that I participate in that I'm able to provide a bit more feedback on in the next slides. So I am fortunate enough to work with Dr. Fenella J. Kirkham with the Hope Kids 2 study, in which we are trainers for another treatment option for sickle cell disease, voxelotor. And this is where a molecule stops polymerization. This drug increases hemoglobin and alters the oxygen affinity. So the Hope Kids 2, our basic requirement is training users on how to perform TCD and to ensure the protocol that is in place is followed appropriately, and that quality TCDs are used, because TCD is the primary endpoint for our study. So we will review on how we were able to train and ensure quality exams, primarily with the beginning of the pandemic, and how we performed remote training and how we continue to perform remote training. I would like to take a moment to highlight Dr. Fenella J. Kirkham for all of the accomplishments she has made and continues to make on pediatric neurology. She is out in London at the University College, and she is a professor of pediatric neurology. She has extensive knowledge, over 700 publications, and I am beyond honored to work along with her in the Hope Kids 2 project. So the tools we have used when performing remote training include what we have available to us. We have used the Xeroscope, which was provided through Dr. Robert Adams, and you can see in the diagram here how we have set up our stations so that we could see the right side and left side of the patient being scanned, so we could ensure proper probe placement and advise on how to optimize the angle and to find the middle cerebral arteries optimally. We were in Nigeria, Kenya, the Middle East, Europe. We were training through the whole world. We were reaching out to many different areas and training many different sonographers and physicians. And this worked ideally for us to reach out to all of these areas to teach and train medical staff members on how to perform dedicated Doppler TCD. Now, this picture shows you what we had set up and how we looked to the medical staff members we were training. The iPads were basically our faces, where we could communicate to them and see where they were scanning. On our screens, we saw 4 quadrants. We saw the image of the ultrasound machine itself, and then in 2 quadrants, we saw the right side and the left side of where the probe placement is on the patient's head. And then in the third quadrant, we were able to communicate with another team member or with the medical staff on site that were learning. Now this worked very well for us to have these different stations for each of us to be in and train these individuals on the other side of the ocean. So here is another fun slide showing the TCD control room. It is not uncommon to find Fenella, Dr. Kirkham, and I with multiple machines running at the same time at different sites, sometimes throughout Africa, Middle East. We will be watching exams being performed remotely while they are being performed to ensure the protocol is followed and that optimal exams are being performed. So we will have all these sites logged in and we will watch them as you see here, and this is how it feels on some mornings when we are watching these exams being performed. So not only are we in a TCD control room, but when we travel, we are logged in. Commonly on an airplane or walking through the airport on the phone, we are seeing these exams being performed in real time. So here we are on the plane, 38,000 feet in the air, logged in, watching an exam being performed in real time in Africa. And amazingly enough, I've never had anyone ask, what are you looking at on that laptop? Even though I always find it quite amazing that we are able to do this each and every time. Now we'll just review briefly of what these different parameters look like on the TCD machine when you do find mean velocities that are in the different range of normal, conditional, or abnormal. So the normal mean velocities, as we mentioned previously, below 170 centimeters per second is the normal range. So here we have on the left a mean velocity of 133. So this is a normal mean velocity for our pediatric sickle cell disease population. Our conditional mean velocity is 170 to 199 centimeters per second. That is the range for conditional. So here we have a mean velocity of 179. This is a conditional mean velocity for our pediatric sickle cell population. And in the bottom right, you'll see we have a higher mean velocity of 201. So once you reach 200 and above, that is your abnormal mean velocity threshold. And here we have that abnormal mean to show you what these will look like on TCD. Moving along, our next topic is gene therapy. So what is gene therapy? Well, each of our cells contain DNA, a molecular code that makes up our genes. So we'll think of this as a set of instructions on how to build and support each cell inside our body. These instructions can sometimes have typos or mutations, and most of the time mutations aren't major consequence, but sometimes they can hit critical parts of our genes. This can harm our cell's ability to properly perform their assigned task. This is what happens in sickle cell disease. So gene therapy uses specialized molecular tools called CRISPR-Cas9 to fix faulty genes and restore the normal function of your cells. So primarily bone marrow transplants were the only cure for sickle cell disease, and finding a matching donor could be a major obstacle, and there were significant risks associated with the treatment. So that is why we have evolved into another option for treatment for sickle cell disease, and that is gene therapy. Now, CRISPR is an acronym for clustered, regularly interspaced, short palindromic repeats. This is basically a family of DNA sequences. And what is happening is the DNA is cut at a desired site to either modify, replace, or disable the gene, or activate or repress its expression. So it's altering the DNA in this way that scientists have adapted for a revolutionary technology. It also poses ethical, social, and environmental challenges, unfortunately. So this does need to be addressed further, but this is another treatment option for sickle cell disease. Next, we'll review briefly stem cell transplantation. The American Society of Hematology has guidelines published for sickle cell disease and stem cell transplantation. There are studies in place, one in which shows ages 16 to 65 with severe sickle cell disease. 26 of the 30 patients reversed the disease. They had normal hemoglobin, fewer hospitalizations, and lowered the use of narcotics to treat pain from the disease. Research continues to follow the patients and tracking the success of this approach. Next, we'll continue on to talk a bit about other research that is taking place. This one in particular is in the Congo of Africa, and I would like to mention Dr. Nicole O'Brien for her efforts and continued research on patients over in Africa with sickle cell disease. And this particular patient she was speaking on a webinar recently was the concern of watching the pulsatility indices along with the mean flow velocities when we are providing transcranial Dopplers. Now, this particular patient had mean flow velocities from 90 to 106 to 141 on 3 subsequent TCDs. Now, these mean flow velocities are all within the normal range on a pediatric sickle cell patient. However, secondary to the blood flow not meeting the metabolic demand of the brain, the microvasculature vasodilated, in which caused the pulsatility indices to decrease. On the first TCD, it was 0.83, the second was 0.51, and finally it was 0.36. And this particular patient passed away from a stroke 2 weeks after this last TCD exam. And here TCD is making its way into the news. With sisters in San Antonio, Texas, one in which with sickle cell disease had suffered a stroke, a devastating stroke, which had put her into the hospital, and which would never have happened if she were receiving her annual TCDs. So the importance of TCD and the lack of it accessible to areas, even here in the United States, and in particular this location in San Antonio, Texas, in which TCD could have prevented this stroke. Now, other considerations to be mindful of when providing transcranial Doppler is the machine you're using and how your machine works. There are some variabilities and slight differences between the different dedicated Doppler transcranial machines. There is a development of a flow phantom for TCD quality assurance. In this article, I was lucky enough to be a participant of where we analyzed the different machines to show that there are slight differences in dedicated Doppler TCD machines, even when doing exams on a Doppler phantom. So always ensure you are aware of how your ultrasound device analyzes the mean flow velocities and do correlations with your exams to CTAs, angiograms, MRAs, clinical findings, Be aware that there are possibilities of some differences between your devices. In conclusion, TCD is a proven method used to identify stroke risk in our sickle cell pediatric patient population. There are unique techniques and limitations to note in this patient population. Never settle for the first waveform identified. Always search for those high mean velocities. You cannot fake a high mean velocity, but you can miss it. And this high mean velocity is identifying what stroke risk our patients are at, enabling us to prevent strokes and provide intervention before anything critical may occur. There are many advances in healthcare and treatment in sickle cell disease that we should be familiar with. And most importantly is the effectiveness in having TCDs accessible to prevent strokes in sickle cell disease.